Hello, my name is Keith Farnes, and the topic of this course is pandemic. This course is approved by the AARC for 1 live CRCE credit hour. After taking this course, you should be able to describe the stages of pandemics, discuss historically significant pandemics, and contrast historical pandemics with coronavirus 2019. What defines a pandemic? An epidemic is defined as an outbreak of disease that spreads quickly and affects many individuals at the same time. A pandemic is a type of epidemic with greater range and coverage, spreading over countries or continents. It affects an exceptionally high proportion of the population. Every pandemic is an epidemic, but not every epidemic is a pandemic. Pandemics often come in waves, and the cumulative morbidity rate, the number of people who get sick over the course of all the waves, often exceeds 50% of the population. Before we get into this course, let's preface with a few more vocabulary words that are necessary to discuss pandemics. Passage is the name for a phenomenon describing an organism's ability to adapt to its environment. When an organism of weak pathogenicity passes from animal to animal, it produces more proficiently, growing and spreading more efficiently, increasing its virulence. This phenomenon was demonstrated by the French scientist C.J. Devine when he was experimenting with blood swarming with anthrax. He determined the lethal dose of this blood for rabbit A to be 10 drops. He infected rabbit B with A's blood, and then C's with B's blood, and so on, until he had infected 5 total rabbits. The lethal amount of blood had shrunk from 10 drops to 1/100th of 1 drop. Passage enables viruses to become more efficient killers. However, there is a balance. This cannot continue infinitely. If a virus becomes too lethal, it may kill its host before it's able to infect another. Virulence is the ability of a pathogen or microbe to damage a host, and attenuation is a process developed by Louis Pasteur to weaken a disease used to develop vaccines. As a pandemic progresses, it moves through various intervals that are determined by specific characteristics. We'll go over these next. The Center for Disease Control and Prevention has established a framework of influenza pandemic interval definitions. This framework was created using the broad WHO phases and digging into more detail to characterize the intervals by specific transmission-related indicators and the types of response activities that should occur within each interval. The duration of these intervals can be from weeks to months, depending upon the virus response. Although COVID-19 is not a flu virus, this framework is being used during this pandemic. Investigation interval. The investigation interval begins when a new virus, in this case COVID-19, is identified in humans or animals anywhere in the world that is judged by experts to have potential implications for human health. During this interval, public health actions should include targeted surveillance and epidemiologic investigations to identify human infections and assess the potential for the virus to cause severe disease in humans. This includes assessing person-to-person transmission, co-investigation of animal outbreaks with animal health representatives, and consideration of case-based control measures such as antiviral treatment and antiviral post-exposure prophylaxis of contacts for infected humans and isolation of humans and animals that are infected. The CDC's recommendations and reports note that with the H7N9 and H3N2V viruses, animal investigations identified circulation of influenza viruses in birds and swine and identified the reservoir of these unrecognized viruses. The CDC administers an IRAT, or an influenza risk assessment tool, to determine potential for emergence, and if the virus really does emerge, the severity of human infection. We will cover the IRAT in detail later in this course. Recognition interval. This interval is initiated when increasing numbers of human cases or clusters of infection are identified anywhere in the world, and the virus characteristics indicate an increased potential for ongoing human-to-human transmission. In this stage, public health action should focus on control of the outbreak, concentrating on potential use of case-based control measures, including treatment and isolation of ill persons and voluntary quarantine of contacts. Initiation interval. Initiation of the pandemic wave. This interval begins when human cases of a pandemic virus infection are confirmed anywhere in the world with demonstrated efficient and sustained human-to-human transmission. Here, efficient and sustained transmission is defined during an event based on the epidemiologic characteristics of the emerging virus. For example, efficient transmission could be a household or an institutional attack rate of greater than or equal to 25% in more than 3 communities, and sustained could be defined as transmission of a virus for 3 or more generations in more than 1 cluster. Public health officials should continue to implement case-based control measures, and routine personal protective measures like hand hygiene is essential, as is enhanced surveillance for detecting additional cases of the virus to determine when community mitigation measures should be implemented. Acceleration interval. The acceleration of the pandemic wave. This interval is indicated by a consistently increasing rate of the pandemic virus identified here in the United States. Community mitigation measures such as school and child care facility closures and social distancing must be initiated immediately. In addition, efficient management of medical countermeasures and vaccines, if available, are very important. These are guided by the Pandemic Severity Assessment Framework, or PSAF. Isolation and treatment of the infected, as well as voluntary quarantine, will be key during this interval. Deceleration interval. The deceleration of the pandemic wave. This is indicated by a consistently decreasing rate of the virus cases in the United States. Planning for appropriate suspension of community mitigation measures and recovery begins. Preparation interval. Preparation for a subsequent pandemic wave. This interval is characterized by low pandemic influenza activity, although smaller outbreaks may continue to occur. Primary action should focus on discontinuing community mitigation features, facilitating the recovery of public health, healthcare, and community infrastructure, resuming enhanced surveillance protocols to detect subsequent waves, evaluating the response to the initial wave, and preparing for potential additional waves. This interval can last from weeks to months. A pandemic is declared ended when evidence indicates that the virus worldwide is transitioning to seasonal patterns of transmission. Pandemics have been documented in history for over 1,000 years, where humans have been infected and killed in mass numbers by diseases like smallpox, tuberculosis, and the plague. Here are some of the most historically significant pandemics. The Plague of Athens, which struck in 430 BC, is the first documented pandemic in history. During the Peloponnesian War, a disease new to Athens struck the Greek population. In the next 3 years, 75,000 to 100,000 people, which was 25% of the population at the time, died. An Athenian general and historian named Thucydides left an eyewitness account and described the disease as highly contagious with a pustular rash, high fever, convulsions, and diarrhea. He also noted that the ill were tormented by an unceasing thirst. It attacked people of all ages, sexes, and nationalities. Many died within 7 to 9 days of the onset of symptoms. He also observed that animals that would eat the dead, diseased bodies would also die. Survivors of the disease often suffered from disfigurement, blindness, and memory loss, but did develop immunity. In the past 100 years, physicians and scholars have debated exactly what the disease was, but based on the symptoms, the options that seem the most likely are smallpox, typhus, or measles. Social response. Thucydides also wrote that men stopped obeying and fearing the laws as they did not know what would happen to them next. Crime, including looting, burglary, and violence, became more commonplace. Care of the sick. Because of how contagious the illness was, physicians and those that tended to the ill were some of the first to die. Many died alone as no one was willing to take the risk to care for them. Mass graves were created and bodies were buried with no layers between them. They were just thrown in there, likely indicating the mass burial of diseased bodies in a panic to stop the plague. The Black Death was a pandemic that hit Europe between 1347 and 1351, killing somewhere between 30 and 50% of the European population, tens of millions of people. This disease is characterized by lymphadenopathy, sepsis, lung infection, boils, gangrene, and vomiting blood. It killed quickly. Although it has been generally accepted that the Black Death was bubonic plague, just like the plague of Athens, modern physicians, historians, and statisticians debate what the virus truly was. New research argues that it was a viral hemorrhagic fever, citing certain genetic mutations, as well as an incubation period of 32 days, which they say allowed it to spread widely, even with the limited transport of that time. If you, like most experts, believe it was the bubonic plague, then it originated in China. If you believe it was the fever, it originated from an animal host in Ethiopia and then traveled to Europe and Asia. Either way, the Black Death wiped out a Chinese army besieging a port in Crimea. As the general forces dwindled, the Chinese began to catapult plague-infested corpses into the town to infect their enemies. From there, marine routes running between Sicily, Africa, Spain, France, Germany, and more facilitated the spread of the disease. The bubonic plague is most commonly transmitted through fleas, ticks, human lice, and rats. However, over 200 species can serve as hosts. After the pandemic ended, the average lifespan decreased from 35 years to 20 years in the 13th century, then less than 20 years in the 14th century. Let that sink in for a minute. Our current lifespan is about 76 to 78 years. Their average lifespan at that time was only 35 years, and after this happened to them, it was 20 years. Basically, after your teenage years, you were dead. Europe's infrastructure and economy were in disarray due to the lack of strong young workers. However, not all was bad. Some of the positive effects of the Black Death were redistribution of wealth and the end of feudalism. Technological advances like the Gutenberg press for book production, water pumps for mining, and advances in science and medicine like the development of the word system. Since the beginning of the HIV, or human immunodeficiency virus epidemic, more than 70 million people have been infected and about 35 million have died. Today, somewhere around 37 million live with HIV and 22 million are on treatment. AIDS, or acquired immune deficiency syndrome, refers to the most advanced stages of HIV infection. Fear, stigma, and ignorance were three huge obstacles that had to be overcome in order to make progress in fighting this virus. In the 1980s, HIV/AIDS was a death sentence, but in 1996, the life-saving 3-drug therapy was developed, later giving way to today's 1-pill-a-day treatment, allowing the body's immune system to recover. The World Health Organization, known as the WHO, has set a goal of ending AIDS by 2030, but as of now, the rates of new infections and deaths are not falling quickly enough to meet that target. Nearly 1 million people each year die from HIV because they don't know they have it, so it goes untreated, or they start treatment too late. HIV disproportionately affects people in vulnerable populations, and most new infections and deaths are seen where high-risk groups remain unaware or underserved. 75% of new HIV infections outside of sub-Saharan Africa are in men who have sex with men, people who inject drugs, people in prisons, sex workers and transgender people, or same-sex partners of these individuals. These groups are frequently discriminated against and excluded from health services. The 1918 influenza pandemic is probably the best pandemic to compare to COVID-19. In 1918, the most severe pandemic in recent history hit the world, sometimes referred to as the Spanish flu. It was caused by an H1N1 virus of avian origin. It is estimated that 500 million people, or 1/3 of the world's population, became infected with the virus, killing at least 50 to 120 million people worldwide, with about 675,000 of those occurring in the United States. It lowered the U.S. life expectancy by more than 12 years. There is not a consensus on where this disease came from. It's actually not from Spain, as the name suggests. In many countries, specifically the U.S., France, Germany, and the United Kingdom, the press was very restricted at that time because of World War I. Newspapers didn't want to publish anything negative or anything that could hurt morale, meaning a rapid spreading virus wiping out our troops was definitely not spoken about. Spain was neutral during the war, and their papers were free to write whatever they wanted. The disease soon became known as the Spanish flu because they were publishing accounts of the spread of the disease. Historians now believe it probably originated in Haskell County, Kansas. Maybe it should have been called the American flu. Regardless, in the U.S., the virus was first identified in military personnel in early 1918. It is no surprise that the virus spread rapidly through the military. Millions of young men were living in extremely tight quarters in barracks that were incapable of housing their numbers. As a result of the war effort, millions of workers were in factories and cities where there was no housing. Men and women shared beds and shifts, where one shift of workers would return to the hostel and would climb into the beds just left empty by the workers going to the next shift. They shared the same stale air in these rooms and shared cups and utensils. The highest mortality groups were people under 5 years old, 20 to 40 years old, and 65 years old and older. One of the most unique things about this pandemic is the high mortality rate of healthy individuals within the 20 to 40 age group. We'll cover the reasons why in a few slides. At this time, there was no flu vaccine and no antibiotics to treat the secondary bacterial infections that are associated with flu infections. Penicillin wasn't discovered until 10 years later. Medical technology and countermeasures were limited. No diagnostic test existed that could test for the virus. Control efforts were constrained to non-pharmacological interventions like quarantine, isolation, good hand hygiene, disinfectants, and limitations on public gatherings. These were particularly prevalent during the second wave of the pandemic, beginning in August 1918 and continuing through January 1919. Cities that did implement these interventions experienced delayed and reduced peak death rates compared with cities that implemented these interventions later. There was no national, state, or local coordinated pandemic planning. Between June 1st and August 1st, 1918, 10% of British soldiers in France were too sick to report for duty, even though they were desperately needed. Suddenly, in the first week of August, the virus was gone. The British command declared the epidemic was over. August 20th, 1918, a medical journal states, "The influenza epidemic has completely disappeared." They said the virus was benign and non-effective. However, in the U.S., the virus was still at its beginning. Author John Barry states in his book, The Great Influenza, the virus had not disappeared. It had only gone underground, like a forest fire left burning in the woods, mutating, adapting, and honing itself, waiting to burst into flame. The deadly second wave was about to begin. There are three main hypotheses that can explain the phenomenon where an initial wave kills few but the second wave is worse than the first. The first hypothesis is that the waves were totally different viruses. However, this one is very unlikely. Many victims of the first wave showed resistance to the second wave. The second hypothesis is that a mild virus caused the spring epidemic, then encountered a second influenza virus. These two viruses infected the same cells and reassorted their genes into a new and more lethal virus. There is scientific evidence that directly contradicts this, and most modern flu experts don't believe this is what happened. The third hypothesis involves the adaptation of the virus from animals to man. As the virus jumped, it experienced a shock that weakened the virus. Through passage, the virus became better at infecting new hosts and grew more lethal. Denial and lack of action. Throughout the first wave and between waves, physicians argued that disease was not influenza. At first because it was too mild, later because it was too lethal. Royal Copeland, the head of the New York City Health Department and the Port Health Officer, stated that there was not the slightest danger of an epidemic because the disease seldom attacks well-nourished people. Even after 200 infected seamen had just arrived into the city, and he had also just concluded that 20% of the New York City school children were malnourished. Despite that, no action was taken to prevent the spread of infection. Not all remained silent during this time. Dr. Howard Anders, a prominent health official of the time, wrote to the Navy Surgeon General the day after the first sailor became ill. He saw the severity of what was to come. In his letter, he requested help from the Navy authorities to protect the soldiers and the population of Philadelphia from the invasion of influenza. Physicians all over the city begged for emergency planning, the stockpiling of supplies, and lists of personnel who would be available in an emergency. During a private meeting, Cruson said that his number one priority was to keep the public calm. He saw panic and interference with the war effort as being worse than the threat of deaths of thousands. During this meeting, Cruson did agree to start a campaign against coughing, spitting, and sneezing. Local newspapers told readers that the flu posed no danger and that Cruson and his assistant would confine the disease to its present limit. The newspaper stated that no fatalities had been recorded among Navy men. No concern whatsoever is felt by either the military and naval physicians or by the civil authorities. On September 21, 1918, the Board of Health made influenza a reportable disease, meaning that when physicians treated an influenza case, they were to report it to the government to help track its movement. However, their statement stated that they were fully convinced that the statement issued by Director Cruson that no epidemic of influenza prevails in the population at this time is absolutely correct. They went on to say that if the public will observe the following guidelines, the epidemic will be prevented. The board's advice was as follows: stay warm, keep the feet dry, and the bowels open. The advice of keeping the bowels open dates back to the Hippocratic traditions. They also recommend avoiding crowds, and companies were beginning to limit the number of passengers in streetcars. An article published in the Journal of the American Medical Association in August 1918 stated that one of the most vital measures in preventing the spread of contagions was to eliminate crowding. Regarding the military camps, it was written that increasing the space between beds and barracks, placing the head of one soldier opposite the feet of his neighbor, stretching tent flags between beds, and suspending a curtain down the center of the mess table were of proved value. In June 1918, the National Research Council visited Camp Grant, where they discussed pneumonia with Joe Capps, the chief of service at the hospital. He shared with them his disturbing findings about a different type of pneumonia, more toxic and fatal. He had begun testing pneumonia serum prepared from chickens. He believed that since chickens were not susceptible to the virus, infecting them with highly virulent pneumococci might produce a very powerful serum. He planned a series of highly controlled experiments. He also showed the council an innovation he was experimenting with, having the respiratory patients wear gauze masks to prevent spray infections. My research showed that the Chinese had previously used masks during the Great Manchurian Plague in 1910, so maybe he got his idea from them. Either way, they all agreed this would be extremely important when attempting to prevent pneumonia. Capps wrote an article for the Journal of the American Medical Association about his masks. The council was convinced the use of masks needed to be extended to all camps and the public, and new arrivals needed to be quarantined at detention camps to avoid cross-infections with men already at the camp. Wearing a mask in public was eventually required, and a jingle was written that stated, "Obey the laws, wear the gauze." As the infection spread through military camps throughout the country, Capps at Camp Grant was desperate. He began to administer his serum to everyone as soon as it arrived. It seemed to be working. 234 men with pneumonia received the serum, only 16.7% of them died. And you might want to think about that for a minute. Only 16%. That seems like a giant number to us these days. However, more than half of those who did not receive it died. This serum was in extremely short supply. Searches for a solution to this epidemic were desperate. Germicidal solutions were sprayed into the mouths and noses of troops. Iodine and glycerin was used to disinfect mouths. Vaseline with menthol was used in nasal passages. The Chicago Tribune published that the epidemic had been broken, that workers under command of Lieutenant Colonel Mitchie battled the pneumonia to a standstill. In reality, the virus had no intention of slowing. In 10 days, the epidemic exploded from a few hundred civilian cases and 1 or 2 deaths a day to hundreds of thousands ill and hundreds of deaths each day. Rumors were floating around on potential cures. Alfred Stingel, an expert on infectious diseases, gave a lecture where he reviewed ideas that had been suggested in various journals. Gargle disinfectants, drugs, immune sera, typhoid vaccines, diphtheria antitoxin. His conclusion? Nothing worked. The symptoms seemed to be endless and in combination with each other and unexplainable. Visible symptoms may have pointed to dengue, typhoid, or malaria, but the impact on the mental state of the victims would be noted by medical professionals all over the world. Delirium, hysteria, melancholy, insanity, and suicidal intent were observed, but no one could have known the consequences that these mental symptoms would have on the future of the world. The attention of pathologists was drawn to the lungs. An Army physician stated that the only comparable findings are those of pneumonic plague and those seen in acute death from toxic gas. Remember, during World War I, using toxic gas on your enemies was common. Some victims were killed by the virus, destroying enough cells in the lungs to block the exchange of oxygen. The lungs of other victims did not look like normal pneumonia at all. Pathologists wrote of their confusion in these notes that typical consolidation was seldom found. Another wrote that essentially toxic damage to alveolar walls and exudation of blood and fluid. Very little evidence of bacterial action could be found in some of these cases. The Journal of the American Medical Association stated that the pathological picture was striking and unlike any type of pneumonia ordinarily seen in the country. The lung lesions, complex and variable, struck one as being quite different in character to anything one had met with at all commonly in the thousands of autopsies one had performed during the last 20 years. We know that normal lungs, when removed, collapse like deflated balloons. During the 1918 flu, they were full of the debris of destroyed cells and the remnants of the immune system, from enzymes to white blood cells and blood. I talked earlier about how the 1918 flu killed an especially significant number of young adults who are typically spared from influenza due to their strong immune systems, which are capable of creating a huge immune response. In this situation, that strength became a weakness. Ultimately, the immune system of young adults sent its fighters to the lungs to kick out the virus. However, all of the fluid and debris, even though it had good intentions, made it impossible for the exchange of oxygen to take place. The immune response killed the host. Today, doctors would immediately designate this condition as ARDS. What do you need to find a cure? Well, first you need to understand the epidemiology of influenza, or how it behaves and spreads. Second, you need to learn its pathology, what it does to the body, and the course of the disease. Third, you need to know what the pathogen is, what microorganism caused the influenza. If you can identify this, you can potentially find a way to stimulate specific immune responses to prevent or cure the disease. First, epidemiology. This one is easy. Except for a few outlying scientists, most correctly believed it was an airborne pathogen and spread easily in crowds. By this point, they accurately estimated that someone with the virus can infect others from the 3rd to the 6th day after he or she has been infected. They also figured out that people can catch the flu not only by inhaling it, but hand to nose or mouth contact. If someone was to cough into their hand and then 30 minutes later open a door, the next person to open that door would likely become infected. By understanding this, they realized they had little chance of slowing the spread down. Rigorously enforced quarantine and isolation were the only options, and no authority had the power to call for that. That brings us to pathology. Scientists knew there was nothing they could do to help serious cases. Even administering oxygen wasn't working. There seemed to be more opportunities in treating these slower-moving cases, the pneumonias they suspected to be secondary invaders. If they were able to identify the pathogen, then they could potentially prevent and cure some pneumonias. This is where they believed their focus belonged. In 1892, a German bacteriologist, Richard Pfeiffer, identified a small, rod-shaped bacterium that he isolated from the noses of flu-infected patients. He called it Bacillus influenza. He was convinced it was the cause of the illness he was treating. Scientists William Park and Anna Williams were hoping to confirm this, although it had been refuted by bacteriologists all over the world, as they stated they had not found it in cases of the current pandemic. However, B. influenza was particularly difficult to isolate. It is small and usually singular, grows within a very small specific range of temperatures, and is transparent. It's an easy target to miss. Anna Williams found it consistently. She eventually identified it in 80% of all samples from one hospital and 98% of samples from another. Scientists all over the country improved their techniques and began to report also finding the bacterium. It seemed that they had found the pathogen. However, this was disproved at the Rockefeller Institute when they took nasal secretions from patients and passed them through a filter. These filters exclude bacteria. The infectious agent passed through the filter, suggesting that it was not a bacterium. Not all believed their results, as they could not be reliably replicated by other scientists. They would not be able to clear their names until 1929, when pig farmers reported outbreaks of an influenza-like disease. They isolated the Pfeiffer's bacterium in the pigs and injected it into other pigs who did not become infected. Due to ethical guidelines, this was not an experiment that could have been done on humans. You cannot knowingly infect people with a disease. Being able to test this on pigs was the perfect opportunity, and previous animal testing had been next to impossible. Almost all test animals during the war were being used for military projects such as the development of poison gas. Then they filtered the samples and found the infectious agent. Injecting this caused a mild version of the illness. When combined with the bacterium, it was deadly. In the spring, Avery, Cole, and others at the Rockefeller Institute had developed a vaccine that showed promising results at Camp Upton, and the Army began producing this in mass quantities. Avery and Cole also developed a serum that decreased the mortality rate for type 1 and type 2 pneumonias. Other scientists had developed vaccines, but many were useless. In a scramble for physicians and nurses, the volunteer medical service was created. With no cure yet, the Red Cross stepped up to the plate to take care of both civilian and military patients. Nurses were essential to keeping patients hydrated, resting, calm, and to cool the fevers. Confidence in the government who told them everything was fine and the press plummeted. How could one believe that there was no epidemic to fear when their neighbors, who were just healthy and they saw a week ago, were now dead? At this point, doctors were willing to try anything that sounded logical. They stimulated the flow of mucus by mixing irritating chemicals in powder form and blowing them into the upper respiratory tracts. They tried to turn the entire body alkaline. They gave typhoid vaccines hoping to stimulate the immune system. They tried quinine, which last year had been suggested as a treatment for COVID. They injected hydrogen peroxide intravenously. Personally, I'm not interested in this type of treatment. Bacteriologists Redden and other colleagues drew blood from influenza survivors, extracted the serum and injected it into pneumonia patients. This was not a scientific experiment, but a desperate attempt to save lives. This became known as passive immunity therapy. On October 19th, 10,000 doses of a vaccine based on a bacteriologist named Paul Lewis's work were delivered in Philadelphia. The same day, the JAMA published a preliminary evaluation of the vaccine. It was without therapeutic benefit. He did state there was likely a use for it, but not on this. On the 25th, the pneumococcal vaccination was ready and was available for members of the military. There was not enough for civilians, and it was largely too late for the military. The disease had already moved through most of the camps, but they were still fearful of a resurgence. No medicine and no vaccine was developed to cure influenza, and little did they know their masks were useless at preventing it too. Their only chance was to prevent exposure. The virus was spreading across the world. A well-known and respected scientist at the time, Victor Vaughan, stated that if the epidemic continues in its mathematical rate of acceleration, civilization could easily disappear from the face of the earth within a matter of a few more weeks. Some viruses like measles and polio depend on humans for survival. Without humans, they cannot spread. Influenza was not like that. Its origin is in birds. The flu was free to kill as it pleased. Once viruses pass through a population, the population develops at least some immunity to it, and victims are unlikely to be reinfected. After initial explosions, the outbreak ends abruptly. The week of October 16th, 4,500 people died from the flu. By November 11th, the flu was almost gone. The virus mutates towards mildness, and the following outbreaks had significantly lower infections and mortality rate. By late November, the virus had made its way around the world, and the second wave was over. Do you think it was over? After health boards and councils had canceled all orders to close and citizenships to wear masks, after some confident individuals declared that we had defeated this flu, the virus mutated again. The third wave was about to begin. It struck places that had seemed to be spared the first time, like the West Coast. Australia had also largely been spared. This time it was struck, although this wave was only half as lethal as the second. This didn't matter. Oral histories recounted this epidemic in Australia as the bubonic plague. Scientists began to especially note the influence that influenza had over the central nervous system. These became known as post-influenzal manifestations and led to diagnoses of psychosis and schizophrenia. One of the most historically significant consequences of that, and although this is not proven fact, it has been suggested that President Woodrow Wilson's illness was not a stroke but post-influenzal complications. During peace talks in Paris to end World War I, he seemed to go back on everything he had said about peace with no victory. He ended up demanding German reparations and that Germany accept all responsibility for starting World War I and many other provisions that had not been previously expected. Most historians agree that the harshness towards Germany during the Paris Peace Treaty created economic hardships, nationalistic reactions, and political chaos that set the stage for the rise of Adolf Hitler. As late as January 1922, deaths from influenza were still occurring. It finally faded away, but did not disappear. It gradually decreased in virulence and populations became more immune. We eventually got past the experience that killed more Americans than were either killed or wounded in the Great War. We were completely unprepared for the 1918 epidemic, and there have been 10 pandemics over the last 300 years. Recognizing this threat, over the last century, the CDC and WHO have created risk assessment tools in order to aid decision-making during pandemics. Things that must be considered while determining what actions should be taken are virus transmission parameters, severity of disease among different age groups and risk groups, availability and effectiveness of control measures and treatment options, and the impact on healthcare, schools, businesses, and the community. In order to assist in making the difficult decisions, the CDC developed 2 risk assessment tools, the IRAT and the PSAF. Both are designed to be used during the initial intervals when there is little data to allow for updates as new information becomes available and to adapt to different scenarios. Once the IRAT and PSAF have been completed, the results should be communicated to federal, state, and local decision makers to guide the actions to be taken with public health. The IRAT is used when a new novel virus is discovered in humans but is not circulating widely in the population, in order to assess the risk that the virus will develop efficient and sustained human-to-human transmission and the risk that the virus will substantially affect public health. This assessment involves data gathering, discussion, and consensus building to assign risk scores, one for the emergence and one for impact, 4 elements falling into 3 categories: attributes that pertain to the biological properties of the virus, attributes of the population, and attributes of the ecology and epidemiology of the virus. Results of this process can be used to decide whether and how to act and communicate. The scoring process can be repeated as new information emerges. After a virus has achieved efficient and sustained transmission, the next step is to conduct a PSAF. The PSAF, or Pandemic Severity Assessment Framework, in plain terms, determines how bad the pandemic will be. This is primarily determined by 2 factors. The first is clinical severity, or how serious is the illness associated with infection. The second factor is transmissibility, or how easily the pandemic virus spreads from person to person. For example, the PSAF of the 1918 pandemic shows a result of very high transmissibility and very high clinical severity, while the 2009 H1N1 pandemic results show moderate transmissibility and clinical severity for the overall population. Planning and response efforts are organized into 8 domains to ensure that subject matter expertise is properly applied to all aspects of the event. In the CDC Preparedness and Response Framework provided in the lesson materials, the actions for each of these domains for each pandemic level are listed. These include incident management, surveillance and epidemiology, laboratory, community mitigation, medical care and countermeasures, vaccine, risk communications, and state-local coordination. Here's the big question. Were we ready? I think most of us would say no. While it goes without saying that we have made great strides in our readiness for a pandemic since the flu of 1918, there is much to improve upon in the U.S. to help us prepare to fight pandemic viruses. Viruses, particularly influenza, are unpredictable and can cause destruction of both populations and economies. Preparing for public health emergencies necessitates continual and coordinated efforts in every level of government and private sector. The CDC, in partnership with the U.S. Department of Health and Human Services, has created a public health emergency preparedness and response capabilities planning model. In 1999, the CDC competitively awarded approximately $40 million to 50 states and 4 major metropolitan health departments to support bioterrorism preparedness and response. The program continues today in the CDC's Center for Preparedness and Response Division of State and Local Readiness, or DSLR, as the PHEP Cooperative Agreement. Their planning model goes as follows. Step 1. Assess the current state. This is where they assess organizational roles and responsibilities, assess resource elements, and assess performance. Second, they determine strategies and activities, identifying and reviewing jurisdictional inputs, prioritizing domains and capabilities, and developing short-term and long-term goals. Third is develop plans, where they plan organizational initiatives, plan capabilities, plan capacity building, and sustain activities, and plan capacity systems in terms of community preparedness, recovery, emergency operation coordination, public information and warning, fatality management, information sharing, mass care, volunteer management, and more. This program has been in place for over 2 decades now, with multiple updates to keep it current, the most recent happening in October of 2018. The standards they set in this program are supposed to help jurisdictional public health agencies structure their emergency preparedness and formalize their public health agency emergency support functions. How much of this was implemented? National systems can be created, but ultimately it's up to the local areas to put these in place. Budgets. Federal support to build state and local capacities to manage a new viral crisis fell 50% after 2003. Budget cuts are nothing new. They have been happening over the span of 3 presidencies, both Democrat and Republican, and many sessions of Congress. The PHEP's grants went from $939 million in 2003 to $675 million in 2020. Private health providers get money through a hospital preparedness program within the Health and Human Services Department. In 2003, their budget was $515 million. Today, that is down to $275 million. Ultimately, more emphasis was put on fighting more predictable problems like chemical, biological, and radiological terrorism. Some experts say that the federal government failed to step up to the plate in other ways as well. Ellen Carlin at Georgetown University's Center for Global Health, Science, and Security says the federal government could have used their purchasing power to negotiate prices to stockpile and have access to PPE and medical equipment. Masks and ventilators would have been especially helpful. We have known for decades now that if we were to face a pandemic virus, it is extremely likely to be a respiratory illness. Most of our hospitals today are for-profit, meaning it just doesn't make financial sense for them to have tons of empty beds or extra equipment. This is where we need the federal government to step in. We forget. This is a problem in all aspects of medicine. It is a big issue with vaccines. We forget how terrible these diseases and pandemics can be. In 2014, after the Ebola scare, 70% of hospital administrators said they were unprepared for an emerging infectious disease. In 2017, only 14% said they weren't ready. I guarantee you that some of the 86% of hospitals who said they were ready found out they weren't. Summary and review. Let's go over everything we've just talked about. We started with defining a pandemic and going over passage, virulence, and attenuation. Then we covered the intervals of a pandemic by the CDC, which were based on the broad WHO phases. These intervals include investigation, recognition, initiation, acceleration, deceleration, preparation, and then finally the end of the pandemic. Then we covered historically significant pandemics starting with the Plague of Athens in 430 BC, the Black Death, and HIV/AIDS. Then we moved into the 1918 flu, the conditions that led to it, who it affected, responsive officials, the waves, and the race to find a cure. Next, we covered decision-making and risk assessment, the considerations in decision-making and the CDC risk assessment tools, the IRAT and the PSAF. We went over the various domains that are covered to make decisions on all aspects of the event. Finally, we went over our readiness. We talked about the PHEP program and what the CDC and HHS have done to guide states and smaller jurisdictions through their pandemic planning. We talked about budget cuts that have taken place and how we forget about how bad pandemics can be. According to historian John Barry, the biggest lesson of the 1918 influenza epidemic is that leaders need to tell the truth no matter how hard it is to hear. My personal opinion, playing the blame game and covering up information does not help anyone, except maybe the politicians. The end of our current epidemic, COVID-19, only has one path, and that is herd immunity. There are two ways to get there. One is vaccines, and the other is infection. If someone is choosing not to get the vaccine, then they're choosing infection. Unfortunately, those are the only two choices. Please encourage your friends and patients to get vaccinated. It is the wiser choice. This slide shows the sources for this presentation, and if you have any questions about it, please feel free to email me. Thanks for participating.